I think we're going to get started. And before I introduce our speaker, I want to start with an announcement. Maybe that'll give folks another minute to come in. So I'm going to ask Sarah Ransbrigel to come up and share some information about an upcoming day.
Yeah, I just wanted to let everyone know about an event here on April 16th in recognition of the 20th anniversary of the Columbine shootings. It's going to be a full day event focused on prevention of school violence, and I'll pass this around, but registration is open now if you'd like to register.
I think it's $15 for students, which includes lunch.
Right,
so
and $25 for others.
That's a great deal. So it's my pleasure to introduce Lindsey Myers today as our speaker. She is a Colorado native, is that correct?
Yes.
And a graduate of Yale. She's currently the branch chief of the Violence and Injury Prevention Mental Health Promotion branch at CDPHE, the Colorado Department of Public Health and Environment. She's also the president of Safe States Alliance, and she oversees many federal grants at CDPHE, including those funded by CDC and other federal agencies. So, thanks. Welcome.
Thank you. It's really great to be here and to see some people that I haven't seen. I saw Erin over there. I haven't seen you in a long time, so glad to be here. You will see on some of the slides, our branch name is a total mouthful. I blame my predecessor for it all the time, Shannon Bryceman. But it's, we have really grown in our program and in our work in injury and violence prevention. I've been with the department for about 11 years, and prior to coming to CDPHE, I worked at the local health department in El Paso County in Colorado Springs for 4 years, and worked with Dr. Di Giuseppe on one of my very first projects there, a booster seat study. So, I'm going to share a little bit about where some of our current projects are and some of our thoughts around, kind of the field in general and how we try to look at our work through a shared lens. Injury and violence prevention, as you may know, is not funded at the level that chronic diseases and a lot of other things are. And so, I think one of the things that's really great about this field is that the partnerships happen out of necessity, but also leveraging in cool ways. And we're very fortunate at the State Health Department to have quite a few funding sources now. But it's been building over time and trying to take sort of a frame. So, one project kind of goes into another and another. So I'm going to talk just a little bit about our framework that we look at our work in at the state level, and then feature some of the projects that we're currently working on. And then just a couple of thoughts for those of you who are students, recommendations if you're looking to get into the practice side of injury and violence prevention from a public health perspective, and then take any questions that you have. I am notoriously bad at packing too many slides in, so I will probably pace myself and cruise through some pretty quickly, but these are available to you if you would like them. So in our branch, we really see our work as centered around creating healthy, thriving, resilient communities free from injury and violence. This is kind of our mission statement. We want to change the context at the organizational, community, and societal levels to improve the environments where we live, work, learn, and play. And as I mentioned, pooling resources and really thinking creatively around our funding is key to kind of how we approach our work. We address lots of different outcomes, and historically, and still, I guess, funding for injury and violence prevention in the state health department realm, and even more so at local health departments, tends to come through in a topic-specific way. So you'll end up getting all of these outcomes, and what we've really tried to do is figure out how can we focus on the things that are shared across these topic areas and move in a direction that hopefully impacts a combination of the outcomes that we hope to see so that we're doing our work smarter. So we have at different times have different grants that focus topics specifically, but we, as you'll see, really try to kind of take a unified approach to the way we do our work. I am sure you, those of you who are students, are well aware of primary, secondary, tertiary prevention. I'm not actually going to let's talk about it for that long, other than to say that our work tends to focus, for the most part, on the primary prevention end, so before injury and violence occurs. We have a couple of exceptions to that, with opioid work and suicide prevention that kind of maybe live more in the secondary prevention realm, but the bulk of our work is primary. We also use the socio-ecological model. Is this familiar to the students in the room? Okay, good. And so I won't go into that in great detail, but we really see, at the state, there's lots of different players that work on injury and violence prevention. We see public health niche, for the most part, kind of in those outer layers of the community and societal level. So we sometimes do some interpersonal or individual level education or work, but we more and more are really trying to focus on those policy systems change types of strategies, because they have often the biggest evidence and the biggest reach, and also because it's a nice complement to what our partners, say at human service agencies or other more direct service providers, are working on, so that you, within a community, have all of those things going on at different levels. We are big into talking about shared risk and protective factors. This is language that CDC came out with a long time ago, but they have a document that, if you are interested in this area, would be a really great one for you to take a look at, called Connecting the Dots. And it is looking at the links among multiple forms of violence specifically. I feel, contributed to this work through grants that we had in the early 2000s and forward, really trying to, again, be smart with our resources and look at where things do have common factors that might influence multiple outcomes given our limited resources. And so we are excited that CDC now is funding a couple of projects using this frame, which is really great, but it's very central to the work that we do. We also, very central and kind of foundational, is ensuring equity. So we talk a lot about equity, knowing that communities and the structural environments that we live in really determine a very big chunk, 80% of our health. And so trying, again, to work on those organizational, societal, community level factors so that we can have the biggest impact. This is a little excerpt from our strategic plan, and I'm going to go through some of the highlights. But what we tried to do, this is, I know you can't read the fine print there, but you'll see on the slides, I'll kind of walk you through what's in there. Kind of a logic model looking type of thing. But again, trying to identify, can we identify some shared risk and protective factors that reach all of our outcomes? And we wanted to be pretty inclusive of all injury, violence prevention, substance abuse, so not just specific to violence like CDC did. So this strategic plan identifies 4 priority areas: behavioral health, strong community norms, economic stability, and connectedness. And I'll go through each one to tell you a little bit about what it means. These are really kind of global protective factors. We felt like it was important to really take a positive frame, because that was true to the work that we wanted to do, but the research that's kind of informing the work that we do in these areas is a combination of risk and protective factors. There's a lot more research on risk than protection, so we did take some liberties and try not to get too hung up on the nomenclature, but we felt it was important. Our branch right now has 40 people that work in it, and lots of them, we doubled in size about 2 years ago. So this has been very important to kind of center us all around a central kind of frame and the way that we do our work. So first, connectedness is, these are some of the ways that we define it. We kind of mean these 4 big bucket priorities at different levels of socioecology. So connectedness can include outcomes related to social support, either having it or lack thereof, our neighborhoods connected, our youth connected with caring adults, our resources and agencies connected. So we kind of mean by this all the ways you can determine connection. And I'm not going to do this as an example of probably slides I should have deleted because it's too much detail, but we have then in our plan for each of the levels of socioecology some examples of programs or policies that we're doing in service to these outcomes. And again, are trying to look where multiple outcomes are identified. So you will see when I get into some of the program detail, we do some social norm campaigns, some media campaigns. We partner with the university on some of that work for evaluation. We also are working a lot through one of our projects to focus on business partnerships and connecting services within communities. So that is an example. Economic stability and supports is really looking at things like income inequality, economic opportunities, neighborhood poverty, anything that is going to help families and individuals really thrive and be able to take advantage. This is kind of getting at social determinants of health a little bit, and you'll see that we have some specific projects that are working specifically to address this. On behavioral health is a term that we use to mean both substance abuse and mental health, just a shorthand way to say it. This is interesting because it's both a programmatic outcome that we're trying to reduce, say, youth initiation of marijuana use, for example, or opioid overdoses, but it also is a risk factor, of course, for everything else, injury, violence, and chronic disease and otherwise. So we kind of look at it both in the same ways. So we are looking at measures and metrics related to a lot of policies as it relates to behavioral health, looking at norms again, and then access to mental health or substance abuse services. So our role is not to provide the services. The Department of Human Services in Colorado has large grants going out to mental health centers to provide those direct services, but we in public health do have a role in helping ensure access and ensuring that all those pieces of the puzzle are connected. So again, they kind of overlay a little bit between them. And then again, social norms. So this is just some examples of what we mean by that. This gets operationalized a little differently in the different program topic areas, but norms about seeking help is a norm that we want to strengthen. We want to reduce harmful norms around masculinity and femininity. This is particularly important in our violence prevention work and sexual violence work. And then also similarly cultural norms that support aggression towards others. So we hope that if we address these 4 large bucket priority areas, that what we're really doing is we're building resilience. And we mean that more in a community way, and hopefully in an individual way too, but that we are, sort of collectively, when we first set out to do the strategic plan, we had resilience as its own protective factor. And then when we got thinking about it and tried to define it and tried to measure it, we realized it was really a compilation of all those other things. So we are kind of reframing how we look at this a little bit. So this is our current makeup of funding. We have 22 funding sources in our branch, which means pretty much constant grant writing and working with the legislature and trying to get resources brought in. We are very well funded comparatively to other state health departments. And I think in part you see that big state number there, $16 million. That's marijuana money. So that is unique to us, but really I think a great opportunity, and I'll talk a little bit about some of the programmatic work that we're doing there, where when we first learned that the marijuana dollars were going to be placed with injury, I of course could make the connection to substance abuse and injury or violence prevention, but it was a little outside of what we used to do, and we thought, well, the first money that came in was really about campaigns and educating about the new retail marijuana laws, and we're like, well, I guess if we do a good job here, and maybe we can build up some capital with the legislators, maybe we'll get some money to do some programmatic work that we think will be important, and we have been fortunate to have that happen, and so that's really great. Most of our funding sources are actually federal, even though the money is smaller. And again, primarily coming from Centers for Disease Control. We have 2 SAMHSA grants from the Substance Abuse and Mental Health Services Administration, and a hodgepodge of other things, but primarily those 2 funding sources. So now I'm going to get into some of the what we do with that money. Injury surveillance is at the heart of all the things that we do. We spend a lot of time looking at data, using data to identify where problems are, as well as evaluate the projects that we have. We have some specific projects related to improving data quality. So our primary sort of injury surveillance data sets include death certificate data, hospitalization, emergency department data, and there has been a recent shift in the way that hospitalization and ED data are coded from ICD-9-CM to ICD-10-CM. And that's important because when we tell people, here's the leading causes of injury morbidity, those numbers, depending on the coding system, get all out of whack. And so we've spent a lot of time doing work trying to figure out what this new coding system has done to our rates so that we can look at trends over time, and we have some projects specifically dedicated to that. So very few, specific grant that goes to this particular thing, but it's something that we interweave into all of the work that we do. Communities That Care is the example of the program that retail marijuana dollars are going towards. Communities That Care is really kind of not really a program, it's more of a public health framework and process to work with communities to really look at their data, to go through the whole public health process, essentially look at their data, define their problems, identify evidence-based practices, implement, evaluate, circle around again. And so what's really exciting about this is it brought about almost $10 million into our state, and we now have let's see, I think, how many are in there? That slide is a little weird to me. I think there are 47 total communities that are implementing Communities That Care. And so this is an evidence-based strategy for both violence prevention and substance abuse. And it is an example of how we have tried to build relationships with the legislature because what they were interested in is reducing marijuana use, and why they gave us the money. We, in working with them, were able to convince them that, yes, that's important, but we want to, Communities That Care can do more than that, and we should look at other outcomes, certainly other substances, but also other violence prevention outcomes. So we wrote a federal grant to be able to do some evaluation relative to Communities That Care on outcomes not related to substance abuse, and then are using some of the funds to partner to do this work. So it's cool because it's very community driven. We have 4 coaches that work at the state health department who provide coaching to facilitators in these local communities who are then in turn working with their multidisciplinary groups. And they're at all different stages of the process currently, but this is a project that, because of the amount of money that we really have tried to leverage across the board, and we're trying to provide as much support to these communities as we can to see good outcomes. I'm not going to go a ton into data, though we certainly spend a lot of time looking at data relative to suicide prevention. It's one of our leading causes of death, second leading cause for people ages 10 to 34, so obviously a very big issue in Colorado, also one that has historically been way underfunded. We have an Office of Suicide Prevention that sits within our branch that receives about $500,000, a little over $500,000 of the state general fund dollars to be able to, address suicide for the entire state, and that is not very much money. So we have been lucky in that, really over the last year, we have started to get some additional grants and some additional support and attention from the legislature to address this issue. Here are some of our priorities that we work on. Man Therapy, which is a social norms campaign focusing on working age men, the Gunshot Project, which is unique in that we're partnering with gun retailers and firing ranges to do suicide prevention messaging. We have some work with hospitals and emergency departments to do follow-up for people who have attempted suicide or appear in the ED with suicide ideation. Zero Suicide is a model that's really helping kind of at a systems level, hospital systems and other types of systems to really understand how to recognize suicidality and how to treat it. Those types of things. Sources of Strength is a school-based kind of community, looking at the school as a community suicide prevention program, and then a whole host of other kind of key projects. And you will see as I go through some of the priority areas for suicide prevention, we are actually funding through other sources of money. So, for example, Sources of Strength is evidence-based for suicide prevention, but we are using funding from rape prevention education programs and other things because of the shared protective factor of building connectedness within students to caring adults. So lots of interesting work there. We also house the Child Fatality Prevention System, which most states, I think all states, have a child fatality review or child death review. You may know of it as. Lori is one of our local coordinators, so she's well versed in this area. But we basically look as a system, look at all child deaths that occur under the age of 18 and review the circumstances of those deaths with multidisciplinary teams, and then identify strategies to prevent similar deaths in the future. We had legislation that passed, we've been doing this since like 1989, I believe, for child fatality prevention, but we had legislation that passed in 2013 that gave us some money, which helped, and also moved the review of the local deaths, or the deaths from the state level to the local level, and that's why we now have 43 local teams. It's, I think, one of my favorite programs because it is very multidisciplinary and very localized at this point, and so it's kind of got a nice feedback loop. So local teams review the cases and they enter data into a data system that sends it up to the state level. We aggregate it, get the data back out, and then together, all told, there's about 800 people involved in this process. But we come up with recommendations to the legislature every year and to other state agencies about what they can do. So this slide just goes into detail about some of the recommendations. For sexual violence prevention, this is a program that has really evolved over time. When I first started working there, funded a lot of rape crisis centers to do prevention work, and realized that it's very hard for crisis centers. Some can do it very well, but it's very hard to really do primary prevention work when you've got people coming in your door and you have to address the crisis that is happening and give people services. And so over time, we have really shifted this funding to fund agencies and communities that are really working on kind of this community and societal level. So we have some initiatives around creating protective environments. We do some work around hotspot mapping with youth, and so we have grantees that work in schools, working with students to identify places within the school building, and in some cases, some grantees are looking at it more in a neighborhood, outside community level, about where they feel unsafe, and working with decision makers within the school or within the city council to address those areas and make some kind of systemic changes based on what they see there. We also are focusing on strengthening economic support, so we have some priorities related to supporting things like family-friendly business policies and for businesses, so that families have sort of the support that they need from their employer to take care of their families, and that is a kind of an exciting new frame that we have used, not only this funding but funding from several other funding sources to kind of build up over the last couple of years. And then we also currently have a research study, which is a little bit different. We've had a handful over time, but usually we leave the researching to the university, and we take those research findings and try to then implement based on the best practice. But I also feel like it's very important for practice to drive research as well, and so this is an instance where we had an idea, and a funding announcement came out from CDC that was looking at evidence-based practices for sexual violence perpetration among youth. And so we found some researchers at Rochester University in their Injury Control Research Center and the University of Florida to evaluate the Sources of Strength suicide prevention program for sexual violence prevention outcomes. So that is an interesting project. It's a kind of a randomized design with 20 schools that is entering its final semester of data collection. So I'm excited to see how it turns out, that we have some good results so far. But it was an interesting experiment. So trying to prove the shared risk and protective factor concept. There's lots of literature that says, hey, these issues are connected or these outcomes are connected. We saw this as an opportunity to say, well, if they're connected and the protective factors are the protective factors, then can we implement a program that's meant for one thing and leave it exactly as it is, but evaluate it and see the outcomes of some of these other issues. And so sexual violence perpetration is the primary outcome with that, but we are measuring substance abuse and like tobacco and opioids and a bunch of other things, since we have surveys in schools and some resources to do it. So there'll be some papers that come out in different topics, I believe. We also are doing a lot of work with opioids lately, as everybody is, kind of the hot topic. Lots on the data side, and then some specific program activities. Most of our funding comes from two sources, from the Centers for Disease Control and Prevention and then the Bureau of Justice Assistance. So we have two grants. Our CDC money current grant is just wrapping up, but we've been focusing on educating healthcare providers about prescribing guidelines and using things like the Prescription Drug Monitoring Program, or PDMP. We have 14 local grantees that are working in their communities to do some provider education efforts, and then more generally to work at the community level to address issues that are important to those community groups. We've done a lot of work trying to make the PDMP, Prescription Drug Monitoring Program, easier for providers to use and access. So some technological type projects. So we've integrated the Prescription Drug Monitoring Program into health information exchanges and into electronic health records and into a third-party website. We've tried all these different things and are now kind of comparing the different methodologies to make it easier to use and access, and see if we can make some recommendations to the legislature about what they should do moving forward to make that more sustainable. And then some work on some distinct projects working with Medicaid and trying to do some data projects that link Medicaid data to death data to prescription drug monitoring data. So lots of work on the data side for that one. On the motor vehicle side, we also do lots of data stuff. We have a unique partnership with the Colorado Department of Transportation, who funds two FTE, two positions within our branch at the health department. One essentially to work on their data. So they are required from their federal funding to do reports every year identifying kind of the major issues for motor vehicle safety. Those reports were initially not that useful to communities, and so we pitched an idea to say, hey, if maybe we help with analyzing the data and then we help communities use their data. We don't have any grant money, or we didn't at the time, to do a lot of motor vehicle community work, but they do. So can we help you do your work better, because we have shared outcomes? And so it's a really unique model that other states are trying to look at. We have several on the programmatic side. We provide a lot of technical assistance and support to CDOT's grantees, essentially, and so they have grantees that are working on everything sort of behavioral, I guess, related to motor vehicle safety, so car seats and seatbelts and impaired driving and speed, and so we help them help them kind of revamp their grant making program, and then we also are helping their grantees do some evaluation work. So that's kind of cool. We do have a request for applications out right now related to impaired driving, where again we're trying to partner with CDOT and they are interested in taking more of a public health approach. So they let us experiment on us applying for, us writing an application for communities to respond to versus them, and that they'll run all the paperwork, so it works out pretty good for us. So we're trying to do some unique things to see if we could do that. Yes?
For impaired driving, is that just alcohol, or are we looking at marijuana and opiates and everything else?
Alcohol.
I know that's a hard...
Yeah. I mean, it's really framed around alcohol, but I think that there's room to look more broadly at those things. So I think I can't remember the close date, but there's still a couple weeks left. So if communities are interested in applying, it's meant to, to take more of a public health approach, and I think that there's a lot of synergies around there. But alcohol, despite the attention on marijuana, alcohol is our biggest problem still. So that's our primary outcome of interest there. Essentials for Childhood is a grant that is really comes from CDC, and it is a child maltreatment grant, but really looking at very upstream approaches to build safe, stable, nurturing environments in relationships for children. And so we had a grant that ended a couple of months ago, and we're fortunate to recompete, and we're one of 6 states selected for another 5-year round of funding for this project that's a little more specific. So we are focused on specifically looking at some gaps in enrollment for social programs like WIC or SNAP, food stamps, you may be familiar of them calling. So in Colorado, this was something that we were very shocked by, but we are ranked 45th and 48th in SNAP and WIC enrollment in the country. So looking at those who are eligible versus those who are actually enrolled. And so we saw this as something that would lead to some partnerships with our partners and internal to the health department around nutrition services, and then our human service partners that run the SNAP program. So this is kind of newer work. We have 5 pilot sites that are going on to provide some extra staffing for local agencies to be able to kind of look at what the barriers are to enrolling in these programs and then to address them. We also are working through that project again on family-friendly work policies. So some unique partnerships there that are happening, and then also community norms work. So specific around help seeking and kind of raising the norm that child maltreatment is a community issue that we should all care about, and that community prosperity is, we all have a hand in that. So we're partnering with the Department of Human Services, who also had some social norms work happening, our community norms work. And so, again, we spend a lot of time sort of leveraging funding with partners internal and external to the department so that we can make the projects a little bigger. Retail marijuana education, I've mentioned a couple of times. Our primary responsibility here, largest, is around public education campaigns. So the first few years, this was, as I mentioned, really about educating what are the laws in Colorado, and now we are turning to a little bit more behavior change type campaigns, so targeting specific groups, looking at the data, so like pregnant and breastfeeding women, looking at retailers at the point of sale and the information that they give, focusing on the more tourist population. So we have some specific campaigns, and then some around youth as well. And lots of work going in there, and lots of evaluation as part of that. We also use a small portion of that money to do community-based education, and are focusing on Latino communities, or Latinx communities, I should say, and the kind of mass marketing messages and social marketing strategies that we are using for the general population were not resonating as much with that community, and so we funded local grantees who work with the populations to do some special, more community-based work around that issue. And then this I think is the last one of the programs. We also have a funding right now specific to alcohol epidemiology. This is a pretty small grant from CDC, but a really good opportunity for us because, as I mentioned, very well known, alcohol is a big problem, but no one has money to address it in this prevention kind of way. So again, looking at data and really helping pull together all of the data sources where we have information around alcohol and then looking at it with some different outcomes, and then really looking at policy strategies that are known to be effective. So such as these listed here are from CDC's community guide, but examples of policies that we're looking at to be able to do that. So there are some other programs, but those are the major ones. We also have been spending a lot of time on the evaluation side, trying to look at how can we take the strategic plan and all those projects I mentioned and really start measuring some outcomes related to these things. So we have built what we've been calling a shared risk and protective factor dashboard. It is just getting ready to go prime time, where we spent a year and a half looking through all of the data sources that would evaluate these different domains, and there's kind of subdomains within each of the major protective factors, looking at data sources from like the Behavioral Risk Factor Surveillance System or our Healthy Kids Colorado survey or other types of data sources that we could measure. And then we've spent time collecting all that data, putting it in the same place, and it's actually searchable by community. So, or you can look at county level, where the county level data is there, as well as the state level. So, trying to look at some trends over time, and we have some analysis ideas, to kind of see which of these things track together and maybe where should we focus our energy a little bit more specifically. So just briefly, and then I'll just open it up for discussion. I thought I'd highlight some of the different types of positions that we have within our branch. So if you are thinking of kind of moving into the practice realm, these are the types of things and different positions that are all focused on injury prevention, but from slightly different perspectives and are valuable members of our team. So we have people who provide technical assistance to local communities. I don't know exactly our total number of grantees, but it is in the hundreds of grantees that are happening, and we provide technical assistance to them across all these program areas. We have some programs that really are more state level programs that are program coordination types of, or grant coordination programs. We have, I think, 5 epidemiologists right now, as well as communications, evaluation, policy, and then sort of our managers and then our coaches, like for communities like CARE, which is a little different than the technical assistance because it's a very specific, intensive coaching model for that one. So, wherever you want to enter into the practice, if you have an area that you're kind of interested in public health, it is very easy to kind of fit into kind of these specialty areas and still work on the topic area, and they're all important. I thought that I would just give some recommendations for those of you who are current students, if you are interested, based on, we do a lot of interviews, and when we get students, these are some of the areas where I feel like people have the opportunity in your programs to take advantage of some of these courses, but may not choose them as electives, and it puts you a little bit behind for some of the positions. So, and this was true for me in school too. I didn't take an evaluation class in school. I really, really wish I would have, because I've spent a lot of time doing evaluation. I've built skills over time, but I would certainly recommend, if you are interested in public health practice, whether it be at a local health department or a state health department, a hospital injury prevention person, I know there are courses and you should take them because it definitely is a big part of what we do. Epi students, I know it is hard to become fully proficient in SAS in a master's program, but if you are really interested in Epi, dedicate time to really building those skills because it gives you an edge in the interview process for sure. And especially if you are interested in the practice piece, I believe that there's an elective called Public Health Surveillance. Is that still true? Okay. I was like, I'm pretty sure. But I think that's, a great course that is really helpful. Another thing, this is more just my own personal wishes for my master's program, but I wish that I would have taken more policy classes as well. I spent a lot of time analyzing policies and have learned over time and have had, amazing kind of on-the-job trainers over the years. But this is something that if you do have an opportunity in your school to at least get some basics, it's very helpful. And then really learning about authentic community engagement is a big part of what public health practice is part, whether that's partnering with different stakeholders or looking at working with communities directly. Just really important to have some kind of basis for that. And from positions that we hire, all of these things are very attractive for different types of positions. Opportunities for new students or new graduates. There are often, opportunities at state or local health departments to do internships or practicums. We have a couple of students generally every year, and usually it's people that approach us or come through various professors here looking for opportunities. We do see it as our responsibility to try to help mentor students and try to help bring people on board. It is very important to get a good project fit, though, both for what you are hoping to get for your education, as well as what we might need to help us out on the projects that we're working on. Local health departments, and Lori and Ritza, who's also working at a local health department, can speak probably more to this, but there historically had not been a ton of local public health injury and violence prevention folks. There are little pockets. I had a job in El Paso County where I was violence prevention, injury and violence prevention. Denver Health has usually had someone, but it's really built over time. Local departments are starting to get more money, though, particularly for mental health and substance abuse. So if you are interested in more of a local setting, I think that is that's awesome. It's also in the state world, sometimes there are temporary positions that you can take. Talia, well, I guess now is back as in a temporary position, but before you finished your doctoral program, were in a temporary position with us, which is kind of nice because it's low commitment. You can see whether you really like to work there and kind of get a lay of the land, and then it does give you a little edge in just kind of knowing how things work when you go through the interview process. So I certainly would encourage that, and we do, when we have those, try to ask around and do some searches for particular people within the university. Another great thing to do if you're interested in this type of work is, I'm always happy to help try to connect people with coalitions, either the state level or local level coalitions, as a participant, because you kind of can get to see how that work happens. And if you are, it's always hard when you're new out of school and you don't have a ton of experience doing the things that you're applying for the job in, that it's helpful to have some experience that you can draw and say, well, in a professional setting, I haven't led a coalition, but I participated in one, and here's what I learned from that. And so I always encourage people to do that. There are also professional organizations that are great. As Ashley mentioned, am the current president of the Safe States Alliance, which is a 501c3 nonprofit and professional organization for injury and violence prevention practitioners. We have a student membership that's $30 a year, and as part of that, you get access to cheaper conferences, and we also often have student scholarships, resources, and kind of a connection of other people, say you don't want to work in Colorado, connection to other injury and violence prevention practitioners throughout the country, and there's several work groups. We are really trying to build our student membership, so we've had some special things happening to recruit more students to participate, and we'll probably have some committees and things that are just for students so that we can build that up a little bit. And then the Council on State and Territorial Epidemiologists is another opportunity on the epi side, the data side of things. They have a ton of different work groups and different things, including a section just on injury prevention. So those are great things to explore, and I believe they have a discount as well. There's my promo I have to do as a president for Safe States Alliance. But I'm happy to take any questions that you have. Or comments.
Question. I always love seeing how you kind of connect all the dots within injury and violence, and it made me wonder, I mean, a lot of the things, the shared risk factors would also relate to chronic disease or preterm birth. There are lots of other things.
Yes.
Is there work at the CDPHE level to think holistically about these topics?
Yes, great question. Yes. We've been talking about this for a really long time from the injury perspective, and especially looking at our chronic disease programs, which historically have been better funded and more resourced, have kind of tried to make, like the ACEs study, Adverse Childhood Experiences, you may have heard of, trying to make those connections, saying, hey, this stuff that happens here really comes out over here in these chronic disease ways. And it has, I mean, frankly, taken a lot of years, but really in the last, I guess, year and a half or so, we have some traction. So our violence and injury prevention program sits within a branch or in a division at the health department called the Prevention Services Division that houses chronic disease and nutrition services and women's wellness and family planning, all of these types of things. So we have just completed a strategic map for the division that is all based on these very same concepts and really looking at how we can better within the division leverage resources, particularly those that go to local communities, which see the connections to things in a much, I think, easier, practical way because there's fewer people to address all the issues. So I'm excited about that. So there definitely is. So for example, we are working on kind of a healthy youth campaign as one of our projects that will be funded through multiple sources, including from disease control and some of these things, because, you know, really kind of the upstream factors that lead to people making choices about their health and activities and risk-taking behavior are the same, whether you're talking about injury and violence, you're talking about chronic disease stuff, you're talking about STDs and STIs. So we're starting to try to pull money from different places and different programs and do something in a unified way versus all of, you know, we have a tobacco campaign and a marijuana campaign, something for opioids and something for disease control, because it's crazy making on the local level, and also we could be smarter with the money and probably do things bigger if we joined forces. So we are definitely looking in that. It's really exciting because it's been something that we've been talking about for a long time. So finally, we've, you know, a bit of transition with the new governor, so we're still working out who all the leaders are, but we got the plan, and our intent is to keep it grounded in that approach. So thanks. Yeah.
And I'd also say with CTC, I think at the local level, I've seen working at Boulder County Public Health that it helped our health department be able to get behind kind of a shared framework.
Yeah. That was our secret hope. Yes. Yes, Jean.
So I want to thank you for leading this important work, creating such a healthy environment and to prevent violence. So you mentioned about a funding study related to promote safe, stable, nurturing relationship, and sometimes for child maltreatment, like the one I want to submit to KO1, we have to go a little bit upstream earlier related to interpersonal relationship and how we deal with that. And what particular programs, maybe in the future, you division may support or want to make that happen in order to have a healthy interpersonal relationship, then, you know, intergenerational relationship will be much better to prevent the child maltreatment issue.
Right. I mean, I would say a lot of our projects, Essentials for Childhood, is aimed at doing that. Again, more at the community societal level strategies, because that's the funding announcement and kind of how we want to do our work. But there's a lot of work happening within the Office of Early Childhood at the Colorado Department of Human Services, which actually houses programs like Nurse Family Partnership or other types of home visitation programs that really are public health programs that get at what you're referring to, Shane. But, you know, politics and where programs live within state agencies sometimes shuffle over time. So there are things that used to be housed at the health department and now are housed there. So we partner and kind of why we've, you know, kind of, we see the importance of the upstream factors and are trying to work on, you know, policies and structures that will help enable the programs that work more at the relationship level or individual level to succeed.
So I think what really stuck out is, and also seeing the differences between a couple years ago and now, is how you're able to really partner with these other agencies. Because I've seen it at the local level where they're still fighting over resources. So what do you think has been successful, and where do you think it's going to go in the future, and kind of removing some of that like child fighting for small resources?
Yeah, I mean, I think you have to work at it, and whether you're talking in a local community or at the state level between state agencies and partners, I think it's part of. Like I mentioned, why we're focusing kind of on the outer layers of the sociology. So if you look at it more holistically, we've spent a lot of time drawing pictures of, okay, here's all the best things. Like if a community had all of these things, here is what it would look like, and who can fund what and who does what, and, making some decisions. So, for example, and some of it, is driven by how money comes down and what federal requirements are, and you have to be intentional about the partnership. And so one of the things, like just to use a substance abuse example, the Office of Behavioral Health and Human Services has money from SAMHSA to give to local communities to do coalition building and things like that. It's very similar to Communities That Care, different model, different coaching mechanism, but thematically similar. And so we've been working with them as they create kind of their strategic plan to say, why don't we just say, we'll take this part and you do these things that we don't do, and we'll then try to coordinate and put them in the same community, and then hope to facilitate navigate some of those relationships that we can. But I think it's about finding sort of the win-win. And so, and what I like about primary prevention is if you back up enough, you're funding strategies that people might care, because even within the injury and violence world, the motor vehicle stakeholders really care about motor vehicle, and suicide prevention stakeholders really care about suicide prevention. If you find that common thing that you're focused on that relate to both of those topic areas, you don't have to talk about suicide or motor vehicle anymore. You can talk about this protective factor or risk factor you want to address for your own individual reasons you want to do it. But that conversation shifts, and I've noticed that some of the turf issues that can happen and still do happen sometimes, they kind of fall away because you're on the same team and you're focused on the same issue. And so as much as we can, that's what we've been trying to, we don't get it perfect all the time, but that's what we've been trying to do. Rita and Dr.
You might run out of time, that's okay.
I was just wondering if any of the pieces of your strategic plan, like those graphics, are those available anywhere?
Yes, so the strategic plan is available. The graphics on this presentation, this is my first demo, so our communication person, I was like, we need to have more professional looking things than usually. So she helped me out. But yes, they're available, and you're welcome to use whatever is useful to you. So we have a Violence and Injury Prevention Network, co.org or com, I believe, I can send it out, has the strategic plan, and I'm happy to share it with the network if that's helpful. And we're kind of always revising it, so some of the plan that's currently there mentions resilience as one of the factors, and we've since kind of fallen away. We really felt committed. We wanted to be committed to not having a strategic plan that just sits there that we do, and then every 5 years we kind of come back and talk about it. I've done lots of strategic plans like that, and they're terrible. So we put this together, and we're like, okay, we're just going to start talking about it, and then when we learn something new, and we realize we got it wrong, we're going to change it, and we'll put a new one up there. So we're kind of in that process right now, but it's available. Yeah.
Thanks, Lindsey. And I really like the positive focus and the emphasis on resilience. And you talked a lot about a lot of different programs. I am just wondering how your programs are touching on the older adult population, because they have a lot of these same issues, but most of the programs you mentioned were about youth. So I'm just curious what kinds of programs you're looking at, or what kinds of activities you're doing.
Yeah, I would say it's a huge gap area in terms of where the funding is dedicated. And as you know, we used to have quite a bit of work specific to older adult falls. We don't right now. The CDC stopped kind of funding that piece for state health departments, and then some of the local, or the funding that is available is very kind of one-on-one class-based, which is really hard to do from a state health department. We are definitely talking with lots of our partners at different agencies around aging. I think specifically for our work, we do have some strategies related to suicide in older adults. And I would say mental health and substance abuse, which tend to cut across the age ranges a little bit more. We have had some discussions related to opioids in older adults, and the sort of the connection with prescriptions and falls, and trying to use the same and driving, and we do have some work. We provide some help to CDOT around older drivers, so we don't have direct funding there, but it's something that as a department, frankly, we are not doing well, and trying to carve out what what is this aging space that we should be playing in, but what is public health's role versus human services role. So some of these same kinds of conversations, but there's been, I called last week my aging week because I went to like 3 meetings. I was like, wow, I haven't been to like an aging specific meeting in a long time, and they all happen in the same week. So I'm hopeful that it'll come, and then if we can better define, what is our role in that I think then we can start to work on, finding some funding to support it. I also think some of the family-friendly business policy type of work, it is just as important to have flexibility from employers when you have young children as when you're caring for older adult family members that may be struggling, and trying to incorporate that into our work that we have with businesses is also one area where we're trying to sneak it in. But you're right. I mean, our funding is by and large youth focused, and that is a gap.
Thank you again, and we'll on that note we'll close.
Thank you.